Hi, my name is Phil Cavell. I'm the author of the Midlife Cyclist. I wrote that book 5 years ago, and chapter 3 was its calling card, Will I Die? Dr Nigel Stephens helped me with that chapter immensely at a very difficult time for him. It was during COVID. So I'm going to revisit the advice that we dispensed in chapter 3 in Midlife Cyclist in an extended interview with Nigel. Nigel is a cardiologist and elite cyclist. In this interview, I introduce a concept of sharks circling in the water. They're metaphorical sharks, and they all pertain to different ways that middle-aged athletes can run into heart-related problems. I hope you enjoy the interview. Surfers are always worried about the sharks in the water. Midlife cyclists, especially men, our sharks circling us is heart disease. I mean, it's the big one.
Yes.
You deal with it every single day, so it's not an emotional subject for you, but it is for everybody else. It's the shark, that we're dreading, that we're cycling along and, oh my God, we got chest pain or something happens. So I want to sort of maybe start with that and think about what the top 3 things you see midlife athletes coming into you in clinic with, what they might present with.
So to preface that, I think it's worthwhile saying something about exercise versus health. With the exception of orthopedic problems, which can come from falling off your bike or skiing accidents, most health and certainly most chronic health issues are uncontroversially helped and prevented by being physically active. Dementia, common cancers, it's obviously true. Epidemiological evidence shows us it. But exercise versus the heart is a little bit more complicated because there are some abnormalities and maybe some conditions in the heart which are aggravated by exercise, maybe caused by being physically active. There are lots of things in the heart which are beneficially affected by being physically active and exercising. And there are also people who have treated heart disease who want to still enjoy what they used to do. And it's quite a complicated question sometimes as to what they could reasonably do and what risk is acceptable for them to take.
And in the book, one of the things that I talk about, and you help me talk about, is this apparent paradox that the more you cycle and the harder you train and the longer you train, there seems to be this greater incidence of kind of clots, if you like, or atherosclerosis in the coronary arteries. And this seemed to be a paradox that was seized upon by the populist press. That middle-aged men were killing themselves by training. And that was one of the things that I was trying to sort of meet head on. Yes. Has that advice changed now, or?
Well, I think the understanding has become much clearer. So just to take a little bit of a step back from it, if you sit in a cardiology clinic and evaluate people who come to you with chest pain, not sports people, just anyone, often the way that you would start would be by doing a CT scan of their heart. CT is now a simple test, low radiation dose, very little downside. And the more calcium is seen in the arteries of the heart, the more likely it is that they've got worrisome coronary artery disease. So that remains true. And an extraordinary piece of observational research confounded that simple thing when some sibling pairs were examined by colleagues in New York. And one pair of the siblings had to have run a certain number of marathons and the other one had to be sedentary. And the expectation is that the sedentary ones would have a lot of coronary calcium on average, and the runners, who are less likely to die from their heart, would not. And quite the reverse was found. The runners had lots of calcium. And then we compare that up with another similar piece of observation, which is if you take statins, you will get increasing amounts of coronary calcification in parallel with reducing your risk of a heart attack. And so So just talking about coronary calcium belies the complexity of what we're actually dealing with. The calcium's a marker. It's not the thing itself. The fatty plaques that make up coronary heart disease, the cells within them express bone proteins for reasons quite understood, and therefore they lay down calcium. So some people with some types of plaques do have calcium in them. But the plaques that are dangerous for us, the ones that can abruptly change, as we would say, rupture and trigger a blood clot to obstruct the artery and cause a heart attack, they're physically fragile and unstable. They contain a lot of fat. The other type of plaque is made of fibrous and calcified tissue and is inert. And as long as the artery still functions satisfactorily as a tube, it's a harmless thing.
Yep.
And so the concepts emerged that increasing coronary calcification in people who have healthy behaviours, they're doing regular exercise, they're taking statins if they've got a high cholesterol, may get increasing coronary calcification, but they're not getting increasing coronary risk, quite the reverse.
So it's almost like cycling and endurance exercise is nature's statin.
Yes, that's right. And I would see regularly people who've paid a sum of money to walk in and have a CT scan of their chest, and then they come back and they've got a high calcium score. They're very concerned, but it ain't quite as simple as that. And then we need to evaluate them and hopefully reassure them that the calcium may be there, but it's not about to cause them harm.
I remember when you and I were talking, you had this lovely expression of, it's always stayed with me, I maybe used it in the book, it was like exercise naivety. So you can split the midlife cohort, people who are just coming to exercise, so
Yes.
their bodies are what you called exercise naive, and then you've got the people, the old dogs like you and I have been knocking around for years and years and years who've never really stopped.
Yes.
And the risk profile is actually a little bit different.
The risk profile in one is known and in the other is unknown. I think that's
Nicer put, yeah, well put.
more
Yeah.
the way it is. So if a person has enjoyed sport from teenage years up to the age of 60, they're in contact with their body, they know how they should feel, and also they've done something which is a powerfully protective behavior. And if somebody like that comes to see me and they're embarking on a big challenge, they're rowing across the Atlantic or something, if they've got that history under their belt, I'm not doing a great deal, maybe some blood tests, a couple of simple things, and it almost always would reassure. Whereas a person might have enjoyed sport as a teenager at university and for the next 20 or 30 years has built a career, had a family, neglected the way that they should look after themselves. And with them, it's an unknown.
Yeah.
And they warrant much more of an evaluation if they're suddenly going to stress their system in a massive way.
Yeah. And often what I find from the bike fitter studio, my day job, is that those are the ones that are in a hurry. Yeah.
Aren't they?
Yeah. Because, they've lost that 25, 30 years and their exercise age is different to their calendar age, and they're in a hurry and they want to do the Etap and the Marmot and the Haute Route. And so they are going to suddenly stress their body in a way that, they're not used to.
And you see it quite a lot with other types of challenge events. People want to run a marathon from a standing start, literally, in 4 months.
Yeah.
And quite often they will then be turning up to the podiatrist, the physiotherapist and so on because they've got tendinitis and this and that, because they don't have 20 years of cross-country
That's right.
in their legs.
Yeah.
It's the same thing. You're right. They're in a hurry. And I think there's also something about psychological challenge. People want to do the Étape du Tour. They want to climb more than 2,000 meters in something that professional bike riders think is a hell of a challenge, and certainly to do it quickly and to do it with style.
Yeah.
So it's a huge ask.
Yeah, that's right. Yeah. And like you, the ones that concern me more are the ones that are new to this, in a hurry, and they want to out the blocks, and they,
Yes.
It's all about intensity. And one of the things our colleague, Dr. John Baker, pulled out in the book, or I pulled out through him, was the fact that these ones train harder, this cohort train harder as a percentage of their maximum heart rate than professional athletes. So
Yes.
they're spending too long at this kind of red line. And of course, we're crash test dummies. No one knows what this does to a body that's 50, 60 years old.
Yes, and I'm not a coach, but enough coaches whose opinion I respect say the same thing. If you take a professional cyclist, it probably takes 30 hours a week to reach their genetic potential, of which 25 are spent chatting, riding in a group, and 5 are spent going hard.
Yeah.
Whereas time-crunched amateur folk will do a majority of the 10 hours they can spare going quite hard and quite uncomfortably.
Yeah.
So they're adopting a physiological stress which doesn't seem to work for people who are good at the sport.
Yeah. So if we bring it back to this, we're talking about coronary heart disease. So someone has an event, there's a blockage or partial blockage in the coronary arteries, and then they have whatever they have, chest pain, or they don't feel well, and they come to you, and they might have had some kind of intervention, whether that's some kind of, you can go through the interventions. I guess, what's their prognosis now after their post-issue with their coronary heart disease?
It's a broad group of people with quite a range of future risk.
Yeah.
And so maybe we'd start with people who've had what we in the trade would call an acute event, like a heart attack, and compare them with people who have chronic, reliable and reproducible symptoms because their heart muscle is short of blood and oxygen. So if we take the first group, the care of people having an acute heart attack has changed radically in the last 25 years. They do much better. They're much less likely to get a severely damaged heart muscle and much more likely to return to normal life. And cardiac rehabilitation has been a transformative process for these folk, both in terms of helping them regain their confidence and teaching them about structured exercise, whether or not they've enjoyed it before. So when I'm evaluating somebody who's had a heart attack, who's had successful care, I would ask myself 2 questions. How much has their heart been damaged? Because that informs the expectation of what they can do. And second, how much residual disease in the heart arteries is there? How much of is there still hidden risk in the arteries? And you might get one person who's had one blockage successfully treated and the other arteries look clean and the heart muscle is working normally or near normally. And as long as you plot a graded return to physical activity, you can set the bar pretty high for these folk. There ain't much you would caution them about doing with an appropriate return to activity. And at the other end of that spectrum, you might have somebody who's had sustained a heart attack, who's got extensive heart damage, who's got a great deal of residual disease in their heart arteries. And although exercise is going to be beneficial for this person, it would be in a very different format with a different ceiling and a different volume. And you'd be talking to them about 2 to 3 hours a week of structured exercise, low and medium intensity for half of it, and combining it with strength training, which also has the same cardiovascular preventative benefits. So a lot of the evaluation is where they sit between those 2 poles.
Is there a difference in outcome if the person was an endurance athlete or not an endurance athlete?
So I've got a very memorable person whom I looked after, who I think is quite instructive in all of this. He was a keen, traditional club cyclist, out on the club riding for 60, 70 miles in the group. And a lot of people listening to this would recognise that as the staple of their weekly diet of cycling. And then in the middle of the ride, he sustained a cardiac arrest. He fell off his bike dead. and his club mates offered cardiopulmonary resuscitation by the roadside.
Amazing.
The whole story is quite amazing.
They saved his life there, didn't they?
For sure, and everyone should learn how to do basic life support, because you can save a friend or even somebody you don't know's life. So they did. They saved his life, and they phoned the ambulance, and it was clear what was going on. So the air ambulance came. They came with a defibrillator, and they gave him a shock and put his heart back into normal rhythm. He woke up and he said, "I don't feel very well. I've got a lot of chest pain." And the ECG showed he was having an acute heart attack, and that was the cause of his cardiac arrest. So he was put into the air ambulance. There were a few delays and logistic problems, and after a significant delay from the time of his first collapse, he arrives in a heart attack centre. He had appropriate treatment for his heart attack. The artery was unblocked, treated with a stent. He got better. He went home. And then he came to see me and he said, "Well, I like riding my bike. What do you think?" And given the story, I was very cautious. I thought he's going to have extensive heart damage. He may well have residual, what we call bystander disease. I'm not sure that I can offer him a great deal of hope about returning to the club run. We evaluated him. There was no evidence of heart damage. There was no evidence of residual disease in his other arteries.
Why?
It blew me away. I have to tell you, 50s?
Oh, perfect.
Yes, it was an extraordinary experience. And so in the end, after a sort of period of appropriate rehabilitation and appropriate medication, he returned to enjoying club rides. He was the same. And it set me thinking about what we understand from the sort of basic science of all this versus the experience of sports people who get trouble, because no exercise is a panacea. It doesn't completely immunize you from common things.
No.
And a very distinguished guy, Derek Yelland in University College London, wrote a great deal about what was called ischemic preconditioning, the concept that if you stress the heart muscle by depriving it of blood and oxygen repeatedly, not to the point where it dies, it toughens up and then becomes much more resistant to the adverse effects of having an artery blocked. And I think this is what was going on with this person. His artery was blocked, but his heart muscle cells were used to being a bit short of oxygen and having a low pH. And they therefore were, although some died, many less did than otherwise would have done so. So there is, in this, I think, some of the explanation why people who enjoy endurance sports throughout their lives live longer and get less fatal illness.
Let's look at the other shark circling in the water. And this is the one I see a lot with my clients. They call me up, I need Nigel's number. And I can't give you Nigel's number. So, and it's AF. I hear it all the time with clients. They present into a bike fit and or they're a friend or a colleague or an ex-client and it's always, they're absolutely terrified. This has happened. And it just seems to me to be quite a big thing, and it's always men, hardly ever women.
That's right.
And so I guess that's the other big shark circling in the water we should talk about. What is AF, how it presents, and what you can do about it, and what the prognosis is.
Got it. So atrial fibrillation is a common heart rhythm disorder. It's 5 times more common in masters endurance sports people than in their sedentary peers.
Wow.
And the way that it works is the left atrium is the collecting chamber, so it receives oxygenated blood from the lungs. It's a weak pump itself, but it's mainly a bag, a sort of storage chamber for blood, oxygenated blood, which then passes through a one-way valve into the main pumping chamber, the left ventricle. When we exercise, we pump 6 times the volume of blood through our heart and circulation compared with when we're at rest. So if you're getting a 6-fold increase in pumped volume, half of that six-fold increase is due to an increase in the heart rate. Let's say you go from 50 to 150.
Yeah.
And half, another threefold increase, is an increase in volume of the pumping heart. So we've got these heart chambers which are subject to a great deal of stretch, tens of thousands of times. And although it's not completely understood, what we do know is the left atrium becomes enlarged. I mean, that's manifest and obvious. It's the norm. It's true in me. It's probably true in you. It's probably true in most people of our age who ride a bike. The left atrium becomes enlarged. And although that of itself does not affect the heart's efficiency as a pump, it's just having a larger fuel tank in your car, it makes the left atrium more prone to develop abnormal electrical rhythms. So instead of having a regular electrical discharge and therefore contracting regularly, instructed to do so by the heart's pacemaker, millions of microcircuits of electricity form. And the left atrium, if you observe it during this, instead of contracting regularly, now becomes a useless squirming bag of worms due to these electrical microcircuits. So the left atrium is wobbling. The left ventricle receives this chaotic electrical signal and still pumps, which is just as well, but it will pump rapidly and erratically. So that's AF. And people will notice their heart beating rapidly and erratically, not always, but most will. And they'll notice, if they're otherwise healthy, a 20 to 25% reduction in the efficiency of their circulation. They're riding with the brakes on. That's how they would describe it. I couldn't keep up with them going up the hill. And AF starts off as intermittent, and then it becomes frequently intermittent, and then it becomes continuous. And it's a pretty inexorable progression, although the speed at which it progresses is highly variable, and it may take decades in some people from their first bout of AF to being in continuous AF. We can't cure it, but there's a lot we can do to treat it. And I still enjoy competitive track cycling myself, and many of my fellow competitors in the track centre at the National Masters Track Championship, I've treated, or colleagues have treated with AF, and they're still on it. So it's something you need to take seriously. It's not like a tension headache where you should just toughen up and ignore it. It's something you should take seriously and get properly evaluated and treated. But if it is properly evaluated and treated, it's compatible with a person leading an entirely normal life.
Right.
And one more thing.
No, go for it. No, go for it.
Sorry to drone on.
No droning. That's about as elegant an explanation of AF as I've ever heard, and I've heard a lot of it. Seriously,
Well, there we are. But the one reason that it's important, even if we're not thinking about its adverse effects on performance, etc., is that some people with AF can form blood clots within the left atrium while it's enlarged and wobbling, and the blood clot can fly off and it can cause harm. And just the other day, I saw a person, and he consulted me with what he thought was AF, and I think he was right. And he said, and by the way, I can't work my left leg properly. And I thought he had quite a well-known thing in cyclists, the iliac artery endofibrosis, which is due to repeated flex in the pelvis.
This is a separate podcast.
Separate, I won't go into it.
It's a good one.
I got it wrong. I thought he had that. What he actually had was blood clots forming in the heart and flying off down the arteries of his leg.
Wow.
So it's quite an impactful illustration of why it's worthwhile taking AF seriously and treating it.
But also, for the person who's terrified and frightened, and I refer lots of them to you, they don't need to be worried immediately they're going to drop dead.
Not at all. No. It's not a I've got to admit you now diagnosis.
Yeah.
You need to do a few things to exclude specific reasons for AF. An overactive thyroid gland can manifest as AF. You have to evaluate the heart with an ultrasound to make sure that it's otherwise structurally normal. This isn't an outward sign of a whole lot of other things going on in the heart. And you need to do some electrical recordings of the heart to confirm the diagnosis, because although AF is the commonest diagnosis in people who turn up with intermittent disorders of heart rhythm, it's not the only one. So you need to tie it down, and you need to do this in a structured program with the person as an outpatient. And then you can make a evaluation and make a decision about two things. Should you give blood thinners to prevent the blood clot issue? And that isn't true for everyone. And should you use drugs to suppress the AF, and if so, which? Or should you think about a more intrusive approach, ablation, to try and treat the underlying electrical disorder in the left atrium? And it's horses for courses. It depends a lot on the detail of the evaluation. But it's not, it needs to be taken seriously, but it's not a cause for distress or doom and gloom thinking.
So if I presented with AF, I would be hoping that you told me, Phil, we're going to perform an ablation, because I just like the idea of going in and you're going to burn these errant cells away, and I can walk out there and continue. But that...
Yes, so I think, you know, to the hammer, everything looks like a nail. And so if you're an ablation enthusiast, everyone with AF looks like a candidate for treatment. Fine. Bear in mind, it's quite an invasive, intrusive procedure, done under general anaesthetic, may take several hours, may need to be repeated, and may not render you drug-free. It's a technology in evolution, and in the next 5 years, it may be able to be accomplished more quickly with more of a guarantee of success on the first treatment. So whether a person ends up with ablation or not, you're certainly going to have a trial of drug treatment to see if you can suppress the electrical anomaly. And we have plenty of good treatments with a good side effect profile, which you would start anyway, regardless of whether you end up landing with ablation.
Okay. There's three things I'd like to say. One is the fact that you compete internationally and you're competing against people who had AF suggests that you can make a pretty considered return.
That's absolutely right. You can return to normal activities in all respects. And the only little sort of complexity with this is the business about blood thinners. So we use a scoring system to work out the likelihood of a blood clot forming and causing harm, stroke being the main harm. And if you're a male under 60, you have and an otherwise healthy heart and nothing else going on, you have a relatively low likelihood. And you have to bear in mind that if you ride a bike and hit the ground, you will bleed twice as much if you're on a blood thinner than if not. And so it's a bit of a more complicated calculus.
Fine. Good. So two things also. One is this seems to be a much lower incidence in women midlife athletes.
That's right. Not understood, but we could expand that to almost all the things that we would talk about as abnormalities in men who are midlife and beyond. And women seem to get much less atrial fibrillation, and they get less left atrial enlargement, and they get less of the other adaptive changes that we see in the heart, which may not represent a disease state, but are certainly different from the norm. So there's a big thing about having two X chromosomes that's different and is certainly not understood, because this remains true in women who've been through the menopause and no longer have the effect of estrogen and progestogen in their biology.
So the thing with the two X chromosomes is a lot of the information a lot of the genes that deal with information are on the X chromosome.
Yes, I guess that might be, because there is a narrative in quite a lot of chronic disease biology that it pertains to an inflammatory process. And a lot of people would characterize, for instance, coronary heart disease as an inflammatory process within the heart arteries. And there's a huge amount of interest. We may want to just talk about this, according to your preference, around the interaction between the fat that surrounds the left atrium and the left atrium itself in initiating this abnormality in the AF. This is a burgeoning area of medical clinical research at the moment.
And the third thing, so one of the things I want to say is that when we're training and we're getting fitter, the actual structural changes we're having in our bodies, we have fluid changes and we have all kinds of changes going on, mitochondrial density increasing, but one of the changes that we're looking for, we're seeking, we're trying to embed like layers of sediment is structural changes in the heart.
Yes.
So,
well, and the broader question about whether they represent abnormality or not.
yeah.
And I think what we might say is for the common or garden club man or woman, the changes are subtle rather than gross,
Yeah.
and it seems quite implausible that they represent a disease state, because I think you quoted me, we talked about this before, about, well, where are the bodies if this is such a big problem? I think that there is a much more tricky question about people who are genetically blessed, who get much more extreme adaptations. So I don't think it's betraying any secrets to talk about Miguel Indurain, who had a cor bovinum, as they'd say in ancient Rome. He had the heart of an ox, huge, muscular, huge in volume, representing an extreme. He could cycle up the hill more quickly than anyone. He could time trial more quickly than anyone. And that was because his genes blessed him with an extreme adaptive potential. And we don't know. I've been involved in helping to think about detraining of very blessed athletes who've had marked adaptive changes. And the other thing that's maybe worthwhile saying in all this, I mean, this doesn't really pertain to masters athletes, but black athletes, meaning African Caribbean heritage athletes, have all sorts of difference between themselves and the white or Asian populations, and those differences are more marked in athletes than in sedentary people. So just to quote one example, if we're thinking about an enlarged heart, as a cardiologist, generally we're sort of comfortable if the volume of the heart is enlarged, matching the increase in the muscularity of the heart. So it's more muscular, but it's bigger.
Right.
Like Indurain.
There's a ratio.
Yes, the ratios remain constant, but just the whole thing's bigger.
Yeah.
Whereas you see with black athletes, particularly black sprint, power and strength athletes, is the muscularity massively bigger than in other groups, the volume not so. And if you're a cardiologist and you were shown the ultrasound and not told anything else, you would, whoa, I don't like the look of that. Right. My colleague Sanjay Sharma, who's medical officer for the London Marathon and a real expert in our field, has made in part, his reputation by exploring this difference and what it really means for the long-term health of black athletes.
One thing that we can maybe talk about is the influence of caffeine on your heart health.
Yes.
Because cyclists are addicted to exercise and caffeine, generally speaking.
Yes. So one of my children said of me, and they all think I'm quite a boring person, it all begins with C for you: cycling, coffee, chocolate, and the crossword, Dad. And they're right. And so I'm approaching this from a position of bias. Yeah. Let's just put this out there. When colleagues have looked, because it's a truism in medical practice that because caffeine is a psychoactive drug and because it's a stimulant and that's how it works as a performance enhancing thing, that it must be bad with heart rhythm abnormalities which are driven by adrenaline. And many, but not all, heart rhythm abnormalities are more likely to occur if we have a lot of circulating adrenaline. So it's the understandable sort of inference that if you take a lot of caffeine, you're going to aggravate abnormal heart rhythms. And if you go to see your GP and you say, I've had some palpitation, they'll say to you, please moderate your alcohol and stop drinking coffee. That's what they'll say. When people have looked at this in a more objective way and tried to look at the relationship between giving people caffeine and whether they get more heart rhythm abnormalities, it's been actually much harder to find a genuine link. And as I say, you're just going to have to sort of get a little bit of a health warning with this, that this is the bias of somebody who enjoys 3 espressos before he heads out on the bike in the morning. But the evidence is weak that caffeine causes or aggravates heart rhythm abnormalities. The evidence becomes very strong that if you take a drink, you will do so. So if you swapped Chianti for coffee, you'd probably do yourself a favour.
I said in the book that abstinence makes the heart grow stronger. And you know, if you're going to be an endurance athlete in your midlife, 50, 60, 45, you should be reducing your alcohol and probably cutting it out completely if you're building to a big event.
Yes.
And I think that's one of the things I think that you have been proved right on, especially with respect to AF.
Spot on. It's so complicated because it's embedded in our emotional lives. It's embedded in what fun means. It's incredibly complex. But if you take all that out of it and just say, well, what does the epidemiology tell us? It tells us that even small doses of alcohol are toxic to heart and brain and probably every other bit of us as well. The dose response of that adverse effect goes down to very low levels of alcohol intake, perhaps 3 or 5 units a week. So if it's more important to you to really optimize your sporting performance and to optimize your health, then I suggest alcohol-free beer is the straightforward way to go. And stop indulging in all sorts of complicated special pleading and thinking about it. Just do it.
Yeah, I'm with you. I totally agree. And in fact, you advised me. I had an arrhythmia in 2018, and you advised me change your life, Phil, and stop drinking. And that was the last time I drank alcohol.
Yes, and there's one other thing that's worthwhile saying in this regard, and that's around hypertension.
You want to explain what that is?
Excuse me. So hypertension is high pressure within our arteries. So there's a natural biological distribution of pressure within our arteries. If we measure it in millimeters of mercury in healthy population, it would vary between 100 and 140 at rest. Due in part to genetic variation, some people have a higher number, and it can be due to medical conditions, but can it just be due to genetic sort of variation between people? And that's no problem in terms of the way that you feel, but give it 20 years and it'll damage your blood vessels and increase your risk of stroke, heart failure and kidney failure. So it's a huge public health problem, and as the population ages, it's more substantial every year. And I worked for, again, to sort of hat tip to another colleague for whom I have huge respect, a professor of clinical pharmacology, Maurice Brown in Cambridge University, whom I used to work for. Maurice said to me, when somebody comes with hypertension, ask them how much they drink. And it's powerfully true. A lot of people with mild hypertension can escape medication by stopping drinking. Alcohol raises your blood pressure.
Yeah, and a very good friend of ours and colleague of ours, Dr David Hulse, who contributes to the Midlife Cyclists, he describes it, alcohol as an obligate toxin. The body's obliged to deal with it first.
Yes.
It's a red flag to the body, and whether or not we're enjoying ourselves, the body isn't enjoying itself.
That's right. And one thing we might talk about, but even if not, about the value or otherwise of wearables.
Oh, yeah.
So if you have a wearable, particularly if it gives you a number relating to heart rate variability, and we can talk a little bit more about that, but basically the higher the heart rate variability at rest, the longer you live, all other things being equal. people who drink alcohol get a very powerful signal by measuring their heart rate variability that tells them you're poisoning yourself, because it tanks. You know, 2 or 3 glasses of wine with your dinner, it's much reduced that following morning, and I think that's telling you that your physiology is stressed.
I've never heard a very good explanation about what heart rate variability is.
Sure.
Give it to me. What
All right.
What a great explanation about HRV. What is it?
You're setting me up.
It's a hard one to explain. If
All right. So, the maths is complicated, but you don't need to understand the maths to understand the concept. So everyone's pulse is not regular. It's not metronomic. And if you do it yourself and just feel your pulse at the wrist and breathe in and out deeply, you will feel it speed up when you breathe in and slow down when you breathe out. The process of slowing down is mediated by the vagus nerve. The vagus nerve runs from the base of our brain to most of our internal organs, and the vagus nerve tells everything to slow down and to de-stress. So the act of breathing will activate the vagus nerve. And so therefore, the degree of variation that we get from the speed up and slow down, expressed as a number mathematically, often measured in milliseconds, where you might say 15's bad, and Matthew van der Poel at about over 100 is great. Most people sit between those poles, and it varies according to whether it's a signal of whether our physiology is stressed. When our physiology is stressed, the vagus nerve switches off, the heart rate variability goes down. When everything is chilled out and relaxed, and the body is in a sort of beneficial state, the vagus nerve switches on, the heart rate variability increases.
So it's a slight paradox that you actually want the variation. You want your pulse to be less metronomic. You actually want there to be a variability between the beats.
Well, it may be more complicated. I mean, you're right, but sometimes people draw a false conclusion that it is the variation in the heart rate itself which is what's good for us. But perhaps it's more that that's just an indicator of what the vagus nerve is up to.
Right.
And the vagus nerve, in turn, is responding to all sorts of physiological stresses within our body. If we've got cancer, if we've got an infection, if we've got hyperthermia, there's huge physiological stress, lots of adrenaline is being produced, the vagus nerve is entirely silent. So it's not, I don't think, that the variation in heart rate is the thing that you seek. What you seek is a state where your body is not physiologically stressed.
Right. And in the book, I talk about this. I don't think it's in that chapter, but in another chapter about the autonomic nervous system, the parasympathetic and the sympathetic state. So what you're saying is the vagus nerve is bringing us into a parasympathetic state.
Yes, that's right. A state of rest, and there's quite a lot of interest in the world of sport and exercise science, which the theory, and I think the hypothesis not yet, I think, proven, which says that if you have an athletic person and you track their heart rate variability, you can prescribe their training regime according to their heart rate variability.
Yeah.
High HRV, go hard today. Low HRV, knock it back today. It's a pleasing concept, and the idea that we respond better to training if we train in a relaxed state. But although there's a lot of work going on with this, I don't think it's yet established to be definitely true.
So let's talk about the third shark circling in the water. And you described it to me as somebody turning up with performance that's changed, it's decreased, it's not,
Yes.
not as it was.
Yes.
But it's not really clear what's going on.
Yes. People doing regular sport and exercise are much more in contact with their body, and therefore much more aware when things are not working as well as they should. And it may be as straightforward as the cyclist with a hill that they ride up frequently and is now having to do it in the little chain ring, not the big chain ring. And people who measure wattage when they cycle and compare it with heart rate, and they're now finding that they have a higher heart rate for a lower wattage and therefore a decreased performance. So it's a common reason people come to talk. And it bumps into COVID from 2020 on in a huge way, because for many people it seemed to coincide with COVID and having COVID and not recovering properly from COVID. But it's by no means confined to that. And quite a common thing is to see often a very accomplished athlete who's reached late 60s, and they may have been of national or international standard when they were senior, and now they say, I can't keep up at the club run. And so you have to almost do a process of eliminating common things, which might be an explanation. And for some people, you have to end up saying, well, that's just the way it is, I'm sorry. And for some people, you can provide an explanation, and for some of them, you can provide a treatment. I mean, an obvious example that shouldn't reach the cardiologist and should have been dealt with already is they've become anemic.
Right. Which is a lovely diagnosis for you, because it's a magic pill, isn't it? You can give them an instant cure.
The one that's even better than that is overactive or underactive thyroid.
Oh, really?
You seem like a genius.
Oh, really? Yeah. So for these people, this cohort that rocks up with, you know, a if not a sudden, a tangible...
Yes,
change.
a real, that's not due to the ebb and flow of form.
Yeah, I've lost 50 watts.
Yes, and I've lost it for 3 months.
Right.
Because some people perhaps are a little too self-observant and might consult after a couple of weeks.
Right.
And I hope sympathetically say to them, well, me too. Maybe just give it a bit longer.
Sure.
But let's say, so more, as you rightly say, a concrete example might be somebody whose functional threshold power is normally 250 watts and now it's 200 watts, and that's sustained and it's been for 3 months.
Yeah.
And then you have to have a proper, structured, systematic approach to understand what's going on. And maybe helpful just to say a little bit about the way that you do it. So talk to them in some detail. You know, there may be all sorts of clues that they hadn't linked to this. They may have rectal bleeding because they've got a polyp in their colon and they're now anemic, as to return to the previous example. If you examine them, there may be something blindingly obvious. They've developed heart valve disease and the blood can no longer circulate efficiently around the body. But sometimes that initial sort of inquiry yields nothing. They look quite healthy, but what they're saying is plausible and real. And so what you would do next is to evaluate their function objectively. We can do it with cardiopulmonary exercise testing, a ramp test on a bicycle, looking at inspired and expired gases, heart rate and blood pressure, and that gives you a great deal of information about cardiovascular and respiratory function and what might be wrong. And what I would often do, certainly for people beyond the age of 40, is what's called an exercise echo. So that's a cardiac ultrasound, which would probably show normal findings at rest, get them to go quite hard, and then ultrasound the heart as they're going very hard. And if there's a blockage in a heart artery, which is now manifest as a cardiovascular inefficiency, we would see that on the exercise ultrasound. And although that's quite a big deal for the person, I'm quite pleased because, first of all, we've identified it, we've made a diagnosis, and also we've got an excellent chance we can fix it for them.
Which is my next question. So if we take away the stuff that isn't anything to do with you, other than the fact you've been a good doctor and found it,
yes.
So let's take away the rectal bleeding and take away other issues, thyroid or whatever, and stick with the cardiovascular stuff. Is their prognosis, this group, good, generally speaking?
It depends. It's such a broad thing that the unhelpful answer is it depends.
Not helpful.
I'm sorry. So the prognosis might be excellent.
Right.
Let's take a person So common things. A person in their 60s has developed a narrowed aortic valve. The aortic valve is the outlet valve of the heart. The heart pumps, the blood goes out through a one-way valve. That valve's opened and shut 100,000 times a day throughout that person's life, and it wears out, just like all moving parts on all machines. It's wearing out, and the way it's wearing out is that it's opening to less fully than it should. So it opens partly, and it reaches a point where the heart cannot push enough blood out to meet the body's demands, and so that may manifest simply as a loss of performance. We can fix that. You can replace that worn out valve with an artificial valve, either with a keyhole approach or with a cardiac surgical approach. And after a period of rehabilitation and re-enablement, that person can go back to normal. And although doctors are a little sort of reluctant to talk about cure, it's curative. They're fixed. Good. And as long as it's not so far gone as the heart itself has failed, as long as we've seen it before that point, it's highly rewarding to treat because you can make the person so much better. If we take perhaps another common but more complicated example, you take myocarditis. So that's different. That represents inflammation of the heart muscle. And that may be caused by a virus, and it may be caused by an inflammatory condition such as rheumatoid arthritis, or it may not be entirely clear what's caused it, but what we can see is the heart muscle is inflamed and a bit like a boil in our skin. It's angry and it's not functioning as it should. And so when we look at the heart, it's not contracting well. And when we do an MRI scan, we can see that that's because the heart muscle is inflamed. And that's more involved for several reasons. The first is that you have to tell that person to stop exerting themselves. And I'm approaching that as a person who wants to facilitate people doing exercise, but I can't...
I can back you up on that.
But I can't do that for everyone.
No.
So the first thing is to say, sorry, we've got to let this get better. For some people, it's causing a severe degree of abnormality, and they may require strong medicine in anti-inflammatory drugs such as intravenous steroids to damp down the process of inflammation. And we may need to give medication which can help in the healing process in the heart. And then we need to keep a careful eye on that person to see the process of inflammation resolve, and hopefully the heart muscle function improve. So there it's a more complicated group, and the outlook may be good, but sadly in some cases it may not be so.
And for clarity's sake, so the context here is that exercise, especially intensive exercise, is acutely inflammatory if it's then chronically anti-inflammatory. So
yes.
You're trying to avoid the acute inflammation phase on top of...
Yes, it's observational stuff that again comes from Scandinavia, where they found people who had clearly got acute myocarditis, continued to engage in moderate and high intensity exercise, did worse than people who rested. It starts with that. And that's now part of coaching law. People are worried about that. And so if you've got a viral infection and it's from the throat and above, carry on. And if it's below, stop, or at least...
And that's not nonsense. That's you stand by that.
For sure. If you train with flu, you're stupid.
Yeah. Because it's already an inflammation and you're...
Well, for two reasons. First of all, you're not getting training benefit.
No training effect, yeah.
You're not getting any training benefit. And second, you may do yourself harm. Yeah. So just, have a word with yourself.
Absolutely right. I mean, and this is where having worked with you for, I don't know how many years now, many, many years, what I can say is that, and this is where I think you're superb with my clients, is you totally understand they've got an itch to scratch.
Yes.
And they get it, and they know that you get it. And they know that, if you say, look, get on your turbo trainer and turn your legs over, heart rate, 100, 110, you know that that's important for them to do that, even if there's very limited training effect.
Most people who come to see me for sort of further opinion have already had excellent care. Whatever type of heart trouble they've had, it would be rare to think, I wouldn't have done that. I've never heard you say that in all the years. No, and I've very rarely come across it. And But what the colleague who's looked after them, the perspective they have not had is of the person for whom exercise is as important as their marriage or their job. And so it's a big deal to say, turn that dial down for that person. Yeah. And the point of intuitive mutual recognition comes where I would say, I don't like not training for a day. I'm really bothered if I can't train for a day. And so I might bring a bit of knowledge to the party, but we are, to mix the metaphor, we're on the same page.
But you're part of the tribe.
Yes, and to be honest, in the cycling world, I might well know them, or at least know somebody that knows them.
Yeah.
True.